So welcome and thank you for joining us on behalf of the Midwest AIDS Training and Education Center. We are headquartered at the University of Illinois at Chicago, College of Medicine, Department of Family and Community Medicine. This program is being recorded and will be available later at our website. I will also send everyone a link. Today's program is part of a series that includes a panel discussion on April 28th titled HIV and Infant Feeding in the U.S. Part 2, Panel Discussion, Supporting Parents and Their Infant Feeding Choices. This series is the result of a collaboration between MATEC, the 24/7 Illinois Perinatal HIV Hotline, and the Mother and Child Alliance. I want to give a special thank you to Lori Ayala from the 24/7 Illinois Perinatal HIV Hotline for helping us develop this collaboration and bring these programs to you. The hotline is a 24-hour resource for Illinois clinicians and social service providers, offering expert medical consultation, access to social services, and care coordination for vulnerable people with HIV and their infants. The hotline provides a single point of entry into care for pregnant people with HIV and real-time linkage to specialty obstetric and HIV care. The hotline also acts as official reporting mechanism for the state of Illinois for all rapid HIV tests. The hotline is funded by the Illinois Department of Public Health. It is staffed by physicians, public health professionals, and social service care providers from Northwestern Memorial Hospital, Ann and Robert H. Lurie Children's Hospital of Chicago, and the Mother and Child Alliance. The Mother and Child Alliance was established in 2000 as Pediatric AIDS Chicago Prevention Initiative, or PACB, to eliminate deaths from pediatric AIDS and end transmission of HIV from mothers to their children in Chicago and throughout Illinois. MACA reinforces a safety net during and after pregnancy for birthing parents, babies, and their providers to prevent HIV and other serious, costly pediatric infections in newborns. With funding from the Illinois Department of Public Health, MACA provides comprehensive support to pregnant people and their families through community-based social services and strong linkages to medical care offered in a respectful manner and without judgment or bias. MACA also engages with state and national partners to identify gaps in existing services and address barriers and solutions to strengthen perinatal HIV care. Our speaker today is Dr. Jennifer Howe, and joining us later for the Q&A is Dr. Lin Yi. We ask that you please type your questions in the Q&A box, and we will address them in the Q&A segment later. Dr. Jennifer Howe is an associate professor at the Northwestern University Feinberg School of Medicine in pediatrics and adult infection diseases, with a research focus on HIV maternal health, child health. She is multi-principal investigator of several NIH-funded HIV maternal pediatric cohorts, including the Pediatric HIV/AIDS Cohort Study, and she is co-chair of the International Maternal Pediatric Adolescent AIDS Clinical Trials, called IMPACT, Network's P1115 Very Early Intensive Treatment of HIV-Infected Infants to Achieve HIV Remission Protocol, and a member of the American Academy of Pediatrics Committee on Pediatric and Adolescent HIV. As a translational researcher, her research portfolio targets long-term cardiometabolic effects of HIV and antiretroviral therapy. Dr. Howe is also an appointed member of the U.S. panel on the treatment of HIV-infected pregnant women and prevention of perinatal transmission guidelines panel. Dr. Lin Yi is the Thomas J. Watkins Memorial Professor of Obstetrics and Gynecology and a tenured associate professor in the Division of Maternal Fetal Medicine, Department of Obstetrics and Gynecology at the Northwestern University Feinberg School of Medicine. She is also the Associate Chief of MFM for Research and MFM Fellowship Program Director. As a clinician, Dr. Yi provides full-scope maternal fetal medicine care, with particular interest in HIV. She is the director of the Women's Infectious Diseases Program at Northwestern Memorial Hospital and is medical director of the 24/7 Illinois Perinatal HIV Hotline. Additionally, as a researcher, Dr. Yi leads a large NIH-funded research program that is dedicated to addressing issues of health equity, health disparities, and health services in obstetrics and postpartum health.
Well, welcome everyone. I just want to say thank you for inviting Dr. Yee, Lori Ayala, and myself and Diana McBride to sort of walk through where are we now with HIV and infant feeding in the US. I know it's been a controversial topic and fraught with lots of opinions, as well as data that seems like it's a morass that we need to wade through together. So hopefully we'll be able to do that on this two-part MATEC seminar. So let me just launch right in. A couple of housekeeping slides to get us started. So I want to just include this MATEC statement on equity and inclusion, just to remind you that MATEC has a commitment to take this stance of fair and respectful, unbiased representation of humankind. We're striving to be anti-racist and gender affirming and honoring all people in an authentic way. Additionally, I want to just say that this program is supported by HRSA as part of an award from that grant. And this disclaimer is just that the contents of those of the authors do not necessarily represent HRSA or the US government. I'm going to also tell you that the funding for this presentation was made possible by this particular U01 grant. And we are really trying not to use any trade or brand names of products. If they're mentioned in this presentation, they're just for training and identification purposes. And then, of course, I have no disclosures, financial disclosures or sources of conflict to let you all know of. What I have here on this slide is 4 sort of broad-armed learning objectives. I'm hoping that by the end of the 2-part series, or at least by today's part 1, you'll be able to examine sort of the evolution of infant feeding recommendations in persons living with HIV in the US and also overseas. Hoping you'll be able to describe the updated 2023 DHHS perinatal guidelines that just came out in January, and particularly focusing in on the infant feeding recommendations. We'll hopefully also be able to identify factors which increase or decrease the risk of breast milk associated HIV transmission, and also any resources available for persons living with HIV who choose to breast or chest feed. So can I start out with a polling question here? We just want to know if you are a healthcare professional. There's 2 questions right there that should be on your screen right now. What is your primary professional practice area? And so we've listed 5 there. Just use your primary and single choice, because we're not too savvy to allow several choices at this moment in time. And then, of course, the second question is, does your work involve discussing breast or chest feeding with patients or clients? So I'm seeing that quite a few infectious diseases, 52%, and then our next biggest is OBGYN. So I'm glad Dr. Yee is on with us. Next is pediatrics, then family practice and internal medicine. Great. And I'm seeing that a little over half of you already have work that involves discussing breast or chest feeding with patients or clients. So great. This will be a good session, I hope, for all of us to learn collectively. Let me go to the next slide. Thank you for answering the poll questions and taking time to do that. I have another polling question that's going to pop up now. If you work directly with patients or clients, could you tell us how comfortable you feel discussing breast or chest feeding? And I'll read through the answers there, but 1 is I am very uncomfortable, find it difficult to discuss. 2 is I am uncomfortable, but I can discuss if I have to. 3 is I am comfortable discussing it. And 4 is basically you don't need to be in on this webinar because you are confident and happy to discuss it. We'll give you guys about 30 seconds again. Oh, good. Well, hopefully I have my work not too hard in front of me, because many of you guys at least feel comfortable discussing it, and some very confident. Great. I want to make a note about the language that we'll be using throughout this talk. We're going to use the words breast and chest feeding, and that kind of terminology we'll try to incorporate throughout to describe, how one feeds their child through human milk. We understand also that some of the data or journal articles or publications that I'll be talking about, some of them actually only enrolled or only recruited or only studied women who were breastfeeding. And so in those studies, I may revert to language that is specific to women and specific to breastfeeding, particularly our studies that we'll talk about overseas. But in general, I'll try our best to use breast chest feeding terms and also gender inclusive language, as well as people first language for persons living with HIV. Okay. All right, well, let's get started. What I want to do here is go through the landscape, because a lot has happened between 1998 and 2023. Obviously, let me start with 1998. The DHHS, or our federal guidelines here, had in our initial recommendations in the US that infants should receive formula feeding. In 2002, the World Health Organization put out slightly different guidelines worldwide, which said that replacement feeding should be done when safe and feasible. Then about 8 years later, they pushed the envelope, WHO did, just a bit more to align with specific national guidelines in different countries, and said that breastfeeding for 12 months or replacement feeding. And then in 2016, the guidelines from the WHO changed to mothers with HIV should breastfeed for at least 12 months and may continue breastfeeding for up to 24 months while being fully supported for ART adherence. And what I want to throw in here is right around 2018 to 2020, we in the US DHHS perinatal guidelines started to think about this topic a little bit more. And so we inserted some language that really acknowledged the fact that individuals might face environmental, social, familial, and personal pressures to consider breastfeeding, despite that risk of HIV transmission through the breast milk. And so that was there for about a year. And, we still had that breastfeeding was not recommended in the US, but that individuals who desired to breastfeed should receive some patient-centered and evidence-based counseling on all the infant feeding options that were available at that time. And here we are now in 2023, where we have put out in January that individuals with HIV who are on ART and have a sustained undetectable viral load who have chosen to breastfeed should be supported in this decision. And so we're going to go through some of the machinations of why this has come out the way it has now in January. What's the data and the science behind it? And what are some of the challenges that we face right now, both as providers and also in the community? Just to let you know, obviously the guidelines have evolved or in the timeline that I just showed you, but I think these are sort of the key themes that arose as members on the panel were thinking through and considering how should the guidelines evolve on breast chest feeding. So there was a lot of dialogue with community members, or a lot of ethical considerations at different levels, both local levels and national levels. I think thought leaders also put a lot of consideration into what are the health inequities in populations with HIV, and how are current guidelines aligned with breaking down those health inequities or actually not helping with them. And lastly, obviously in conversations with a lot of community members we really wanted to take into account shared decision-making where risk of transmission for HIV is actually very low in the face of ART adherence and virologic suppression. So this milieu of thought leaders and sort of big considerations churned about, I think, in the last 4 years, and here is where we're at. I'm going to take a moment now and walk you through some of the scientific data. So why, obviously, many of you don't have the question why, but for those of you who have the why question of why is it that we were saying formula feeding in the US and WHO was saying breast chest feeding across the rest of the world, and particularly in low middle income countries like sub-Saharan Africa. And that's because this is one of the earliest studies. This is the MASHI study that was done in Botswana, sub-Saharan Africa. And they really looked at formula feeding versus breastfeeding with zidovudine infant prophylaxis, and evaluated both HIV infection as well as mortality. This dark line that you're seeing there is the group that got breastfeeding plus AZT, and the gray line that's lighter is the group that got formula feeding. Not surprisingly, you'll see on the left that the kids who got formula feeding had lower rates of HIV infection all the way through 18 months. But what was surprising to us in this study was seeing that at around 6 months, there was a clear benefit in terms of lower death rates if the kids were breastfed versus formula fed. Now, all the way out to 18 months and later, that difference in mortality closed. But nonetheless, at that 6 to 7 month age range, it left us scratching our heads thinking, gosh, maybe we should be using breastfeeding in places like sub-Saharan Africa. What then is the HIV transmission risk if you breastfeed and you do this in sub-Saharan Africa? And this is an older meta-analysis, but we're listing out a couple of different ranges in transmission risk. So we're seeing anything between 0.6 to 1.7% risk of HIV transmission between 4 to 6 weeks and 6 to 7 months in those who breast chest fed in lower middle income countries. What about more recent data, though, in PROMISE? So PROMISE is part of the IMPACT, or International Maternal Pediatric AIDS Adolescent Clinical Trials Group. And that trial, what I'm showing you here is the postpartum timeline, where there was 2 groups of randomization. One group, the mothers got triple ARV, and that was most usually a lopinavir-based triple ART, or the other arm was just relegated to infant nevirapine prophylaxis. And you can see that over time, the prevalence of HIV transmission really was somewhere between 0.3 to 0.6% in the PROMISE study. And that's our probably more recent data on transmission risk in breastfeeding moms. I think the real big question, as many folks and I have been thinking about breast chest feeding, is, does U equal U? So we know with sexual transmission that U does equal U, and really there's no transmission sexually if the partner with HIV is actually taking ART and the viral load is less than 200. And we know that for perinatal transmission, U fairly confidently equals U because we don't see transmissions if the pregnant person on ART before and during pregnancy has a viral load that's less than 50 through 3rd trimester and delivery. But the real question is, like I said, what about lactational transmission? Does U equal U there? And so I want to start with some anecdotal cases. In PROMISE, remember, we had about 1,200 mothers on ART, and of those, 7 cases of transmission or breast milk transmission. What you're seeing here on the two graphs on the right are where I've circled the time points where two cases of breast milk associated transmission occurred, one at 14 weeks and one at 36 weeks. And in both of those, the women had an undetectable HIV RNA level less than 40 before and during. And that's why you see these dark dotted black lines showing this low level undetectable HIV RNA. So while we're comfortable that hopefully when you have an undetectable viral load, you won't transmit through breast milk associated transmission, we can't say that it's 0% transmission when the woman has an undetectable HIV RNA level in the blood. So what are some of the reasons why we think that this still happens? Well, I think in breast milk, we find that there is cell-associated HIV. And so what I'm showing you here is cell-free HIV versus cell-associated HIV. And on the left-hand side, I'm kind of detailing what is cell-free HIV. Well, that's the HIV that's floating in your serum when we get plasma HIV viral loads and we send them off to the lab. And it's measured as HIV RNA. And we know that each 10-fold increase in serum or plasma viral load actually doubles the transmission risk through breast milk associated HIV transmission. But cell-associated HIV is not the HIV RNA levels that we measure in the blood. It's the HIV DNA that you find in your resting CD4 cells or in your latent reservoir. And so, you know, in these cases, this cell-associated HIV is actually 10 times more efficient at activating in milk versus plasma. And we know that ART does not suppress the cell-associated HIV that we see in breast milk. So that might be some of the reason why, you know, in PROMISE, they had 2 women who, despite having undetectable viral loads, still transmitted. So what do you do then when a person with HIV asks if they can breast or chest feed? I think we're going to go through now some of the applications, what you kind of have to do in the heat of the moment when you're in the clinic or in the office with that patient. Well, the DHHS guidelines have come out with these 3 big main bullets, and I'll read them out loud, but essentially the gist of it is that we want to make sure that counseling about infant feeding is there for persons with HIV, no matter what, and that information about plans for infant feeding should really be talked about and reviewed early on, antenatally, if possible, and then re-reviewed at delivery. The guidelines also say that replacement feeding with properly prepared formula or pasteurized donor human milk from a milk bank eliminates the risk of postnatal HIV transmission, and that achieving and maintaining viral suppression through ART during pregnancy and postpartum decreases the transmission to less than 1%, but it's not 0. And I just want to emphasize that. So let's take that first bullet point that we talked about in the last slide in terms of counseling and break that down. How do you do the counseling? And I know that it looked like about half of you all felt comfortable counseling. So I'm probably preaching to the choir, but let's go over some of the things that we found to be helpful in our practice. So definitely taking a hard line and prohibiting breast chest feeding has not been the most productive, I think, in anecdotal practice. And it really might inhibit people from expressing their real wishes and plans. So what you don't want is for your patient to lose the ability to tell the truth of what they're doing and actually breastfeed behind your back, and you don't know. So also the hard line really presents a lost opportunity to educate and persons with HIV may then breastfeed intermittently, and that's going to double your risk of HIV transmission. We've also found that if you use open-ended questions, probably something you guys already know, but keep them very non-judgmental and just ask the women about their feeding preferences. We also encourage trying to understand what's the context behind their motivation to breast or chest feed. Is it because they are a proponent of the well-established health benefits? We know, especially from our obesity expert colleagues, that using human milk in the first year of life has clear benefits from a metabolic standpoint. Also, are there other motivations behind why the person with HIV wants to breast or chest feed? Are there cultural norms in their environment? Have they recently immigrated from a country where formula feeding would risk a form of disclosure of their own HIV status? Do they plan to go back home to their home country in the near future and would rather not be stuck in a position of not being able to find formula feeding there? We really try to validate their desires and then educate, obviously. And I can't stress enough how much importance we place on doing these kinds of talks and counseling in the antenatal period, having our OB and our pediatric specialist providers in the room together, ideally. And so here at Northwestern, we're really lucky because Dr. Yee and her colleagues in maternal fetal medicine, and then me and my colleagues in pediatric and adult HIV are able to see our persons living with HIV and pregnant in the same pregnancy multidisciplinary clinic on the same day. So we are able to sit down together with all the people at the table and have the conversation with both the case managers and the patients. And we've really found that to be super fruitful. What about the birthing parents' viremia associated with breast milk transmission? Well, obviously we like to tell them again, as I just showed you in our slides, that high plasma HIV RNA loads are associated, no doubt, with higher transmission. But that even if your plasma viral load is undetectable, it doesn't mean that the risk of transmission through breast milk is 0%. And we re-educate also that this can be also from fluctuations in adherence. Drug levels may go up and down. And then again, transient immune activation that is occurring in the background, that is when the latent reservoir in the CD4 cells, the resting CD4 cells, may express cell-associated HIV. So what are some other things that we usually tell folks? Well, we tell folks, if you choose to breastfeed, we're going to support you as best as we can. And especially if you have a sustained undetectable viral load and you're on ART and you're not having issues with adherence, that we will do our best and support you in that decision. And we also remind our patients that we are not going to call Child Protection Services or similar agencies should you decide to breastfeed or chest feed. And then the other things that came out really recently in January, and I'm highlighting these in the blue boxes, is that replacement feeding with formula or banked pasteurized donor human milk is recommended to really eliminate the risk of HIV transmission through breast milk associated transmission. And so we reiterate that when we're talking to our patients, and obviously we ask about their potential barriers to formula feeding and tell them again that we're going to support their decision of formula feed or breastfeed either way. What I'm going to show you on the next slide is we're going to talk about, they tell you, okay, I'm going to breast and chest feed. What do we do now? And this is our sort of contract or agreement. We don't like to use the word contract because it sounds too legalistic, but we do have them sort of sign this statement. And I think it helps because once the patient has to read through and understand the things that we're really looking for when the decision to breast chest feed has been made, I think it helps them both conceptualize what they have to do and put into practice, but also it becomes real. And I'd have to say that sometimes by the time we get to the statement and the signing and talking through each of these rows that are laid out, there are some women that decide in the end, well, actually, I don't know if I could do all this. And so I'd rather just formula feed, which is completely fine. And there are some women who look at it really closely and they say, yes, this really empowers me to do what I need to do to really get the risk down as low as possible for HIV transmission in the postnatal period. So I'm not going to read all these out loud, but hopefully you guys can hover on them, read through most of them. But they're essentially a summarized version of all the things that we've been talking about in the previous slides. I think the part at the bottom, which is, if applicable, but prior to delivery, that we try to hone in on is that they'll consult with a pediatric HIV specialist prior to delivery if we can. And I think that really helps in bridging between the delivery and the postpartum period. So what are some of the issues that we try to address then once breastfeeding is the choice? These are sort of three buckets that we talk about over and over, both before and after the delivery. So one is, what should the mom do if she has mastitis? How should they breast chest feed? Should it be exclusive? Should it be mixed? We recommend exclusive, and I'll go through some of that data in just a second. And then who should be consulted and who should be doing some of the following activities, which would be viral load monitoring for the birthing parent, infant PCR testing, any additional ARV prophylaxis that has to happen for the infant, how should weaning be handled, and how and who is going to be counseling about mastitis surveillance. So let's take each one of these point by point and go through what we think are the best recommendations. This slide is really showing you a recent or not so recent study that looked at the infectivity or breast milk HIV RNA levels in a group of women who had subclinical mastitis versus no subclinical mastitis. And what you'll see there on the right-hand side that I've circled is that obviously the viral load was higher in the breast milk for women who had subclinical mastitis. And this was at both 4 weeks and 6 weeks. What I'm showing you here is just one time point. So this is why we pay particular attention to whether or not the woman has subclinical or full-blown clinical mastitis. And we really emphasize to the woman that she should be looking for that when she's breastfeeding. What about exclusive breast chest versus mixed feeding? Well, what do we mean by exclusive breastfeeding? We mean no other fluids or food other than the human milk. Mixed feeding would be you're giving both breast milk and other fluids or foods. You're giving a bottle with formula one feed, and the next feed you're giving the human milk. Basically, disruptions in continuous or exclusive breast chest feeding actually raises the HIV viral load in breast milk. And so therefore, we recommend against mixed feeding. And we actually recommend full exclusive breastfeeding for the first 6 months of life. Why is that? Well, this is an older study, but you can see Kovadia et al. In Lancet 2007 are showing in this red line, the red dotted line, are mixed feeders. The green line is replacement feeding, or essentially formula for them. And these lines are both lower than the blue line. So that's telling you something about their survival probability between 0 and 6 months of age. So those who were exclusively breastfed had higher survival and lower mortality compared to the mixed and replacement feeding. And that's why if a woman is going to breastfeed or chest feed, we do tell them to exclusively breast or chest feed up to 4 to 6 months of life. And what about all the other things that were on the slide 2 slides ago, all the bullets about infant prophylaxis, testing of the birthing parent, etc. How often do we do NAT testing on the infant? Well, there's really very little data available to guide us, unfortunately. And what I'm going to give you is a couple of bullets of what we do. And I'm going to put them out here. Feel free to throw out questions in the Q&A. But again, there's very little data. Some of this is guided by how we've done things in some of my studies overseas in Botswana and South Africa, and then some of it's guided by expert opinion. So we try to assess adherence at every visit. I think most people would not disagree with that. So we're asking the mother at every visit, how are you doing with adherence, whether or not she's breast chest feeding. We also recommend frequent maternal viral load monitoring. And this is obviously in the serum, not in the breast milk. And what's really critical is to decide early on what provider is going to do this, because we've seen oftentimes if we're not involved prenatally, the woman actually doesn't even know, is my OB provider going to do it at the 6-week postpartum visit, or am I going to do it with my internal medicine or family care provider who takes care of me, or am I going to do it when the baby sees the pediatrician? Because she may have fractured healthcare where she sees a different person, a different OBGYN, a different internal medicine who takes care of her HIV, and a different pediatrician. And so deciding early on who's going to take care of that viral load monitoring is pretty critical. What's the frequency? In the guidelines, we're a bit vague about it, but, we have said about every 1 to 2 months or more frequently if there's concerns. In some of our studies overseas and sub-Saharan Africa, we have followed schedules of things like at the 1 month, at the 2 month, at the 4 month, at the 6 month, and at the 9 month, and so on if they're still breastfeeding. So again, no hard data, no randomized controlled trials to tell you what is the perfect frequency, but there are some guidelines that we could give. If there's a detectable viral load at any point, there's several options. There's obviously the option to just stop breast chest feeding immediately and discontinue it permanently. There's also options to give previously stored express milk from a date when the person actually was virally suppressed, and then keep encouraging pumping and discarding for the time being. There's also an option to pump and flash heat the human milk before feeding it to the baby. I think you have to take these on a case-by-case basis. Obviously, if the viral load is detectable and it's 51, that's a different scenario than if the viral load is detectable and it's 2000. And then the last bullet I want to talk about is the infant NAT testing. Again, there's no consensus or real hard data on how often or how frequent to be testing the infant with a DNA PCR or even an RNA PCR. I think the most important thing is to be in contact with the pediatric HIV subspecialist so that he or she can recommend or do the NAT testing for you. Presumably, a woman is hopefully only going to breastfeed if that person was already considered low risk to begin with. And so one could potentially follow the NAT testing schedule for low risk. But several experts also feel that going with the high risk schedule for infant NAT testing would not be a bad idea either. So again, the jury is out, but there are several ways to do it. I think the last thing I want to talk about is what do you give to the infant at the time? And again, very little data out there. In the PROMISE study, of course, they were randomized to either the mom got triple ART or the kid got infant nevirapine. And so the question is here, should we add additional drugs for the infant? Should we extend the infant's zidovudine? There are some very conservative specialists who might say 3-drug empiric treatment and treat these infants as high risk for the duration, which is very conservative. And then there are some who recommend additional extended infant nevirapine according to the WHO guidelines. The big thing is just consult pediatric HIV specialists or PEDS ID folks. We're here to help you. How about weaning? How do we do this and what's the best way? Well, the big thing to do is to ask about how long, and no one can, look in crystal ball and tell you this, but about how long does the parent feel as though he or she will be giving breast or chest feeding. And some parents can tell you right away, I only want to do this for 2 to 4 months. I really don't want to do this for longer than that. And then some may tell you, I plan on doing this exclusively for 6 months for sure. And then who knows how long after. And so if you can get an idea before they even start, it helps you to start talking about how and when they would wean. We do know that rapid weaning is associated with increased risk of viral shedding in the breast milk. So that could also increase, theoretically, transmission. But these studies were done in the pre-ART era. And so what I mean by pre-ART era is in the era before we were giving triple drug therapy throughout postpartum for women. We do think that maybe weaning over a period of 2 to 4 weeks may be safer. Again, little data to back that, but that's currently out there. So what are some of the takeaways? I'm going to wrap up and give you guys a little bit of time to answer questions, but I think one, counseling and discussion about infant feeding choices really should occur ideally antenatally. We try to do this in a very non-judgmental manner and present very evidence-based recommendations. Breast milk associated HIV transmission is low, maybe around 1% when the breastfeeding individual is virologically suppressed with excellent adherence, but it's not zero. And so we do like to make sure that that data point is presented as evidence when we're counseling. The only real way to eliminate the risk of breast milk associated HIV transmission is to give replacement feeding. And coordination with your obstetric and pediatric and internal medicine ID providers, I think, is really essential in supporting our individuals who choose to breast and chest feed. Let me pause for a second. We're going to put one of our last polling, oh no, it's not the last, one of our final polling questions up.
I believe it is the last.
It is the last, okay.
Yes.
Good. It's anonymous, so feel free to give us a truthful answer. This just helps us gauge where we might need to reinforce or give more education points on part 2 of this series. You can totally answer number 1 and I will not feel bad. I have thick skin. Oh, well, that's great. Okay. I mean, all right. Thank you, folks, for being honest and answering that last question. I think that really helps us as we, may or may not tweak part 2 of this series. I want to give a huge shout out and acknowledge every single member of the DHHS panel, and particularly those who had a real hand in helping to evolve the guidelines around this particularly important topic. And I've listed them all here for you. This slide gives you guys websites where you could look for additional resources, and these are all MATEC resources. And then my next slide are potentially the 2 most important websites that you might want to go to when you're in the middle of the night or in the middle of seeing a patient and are not sure what to do. Please, please, please feel free to call the hotline. We are there 24/7. That's the number on the right. And then the box on the left is the DHHS guidelines.
And just to clarify the
let me go back.
Yeah, just to clarify on the hotline, is that only for Illinois providers, I'm assuming, correct?
Yes, you are right.
But if you go back to the previous slide, we do have
Yes,
a hotline, what's a warm line for the National Clinician Consultation Center, and those are available nationwide.
Yes, the national hotline, they're great folks too. Several of them are on the DHHS panel.
Yes, awesome resource. Thank you.
All right. Okay, so I will skip ahead. We're going to go to Q&A now. So I don't know, Diana, do you want to drive the bus on this, or do you want me to? I have the Q&A up on my screen.
I can hear you now. Yes,
wow,
we can hear you.
I have a voice.
Great. So Dr. Yee, if you can unmute yourself as well, it won't allow you to. Hold on, let me check. There you are. We're all together.
All right. Hi, everybody. Sorry for the technical difficulties, but I am back. So we have one of the things, first of all, I want to say what an awesome presentation. Thank you, Dr. Howell. Most of the stuff in the chat, in the Q&A, is really around the breastfeeding component and the supplemental. One question that's in here, you did address, but they still have some questions. And one anonymous attendee says that they find that the checklist is very helpful, but it seems very punitive, and that if the mom is agreeing to breastfeed, the language states she is taking significant risk for her baby when the risk is less than 1%. So that's a statement by one anonymous attendee. So Dr. Howe or Dr. Yee, if you wanted to address that.
Yeah, and I appreciate that. I think these checklists were made last year before these recommendations came out. And we still use them. And actually, I actually have not found any of our moms say that they felt, that these were punitive. I think one of the reasons why we want them to sort of acknowledge that there are risks is because sometimes, and that less than 1% is only if your viral load is undetected, you've been adherent to your ART, and you've had a viral load undetected throughout third trimester and throughout your breastfeeding period. So it's not a minuscule transmission risk if you're with viremia. And so there may be some women who are viremic, and we've had that during their pregnancy and postpartum. And so we want to make sure that they know in their case that it would be a risk.
I want to add one thing to that, which is one thing we do a lot in maternal fetal medicine is counsel patients about risk acceptance and risk tolerance for various circumstances. So a conversation I have frequently with patients around this concept of infant feeding is what level of risk is acceptable to them. And I think the person who made the comment said the risk is only less than 1%. But for some people, that might be an unacceptably high risk. Other people might find it that they can tolerate that level of risk of transmission. But I think it's important for us as clinicians and the healthcare community to recognize that everybody's risk tolerance is different, and that helps contribute to the discussion with regard to which decision might be the most appropriate for them and their family.
Okay. Yeah, that's a great point.
Yeah, very good point. There's another one here. It says, why does mixed feeding raise the viral load in the human milk? I thought the mixed feedings changed the gut in the newborn to make it more susceptible to the low level of HIV in human milk.
I can address that from a maternal medicine standpoint. When a person is not breastfeeding exclusively, it means that they are expressing milk less often. And so they're more likely to get subclinical mastitis or clinical mastitis and clogged ducts. And then this can manifest for women, the people living with HIV, in the form of a greater viral load in the breast milk. Now, on the other hand, if a person is, and I'll let Dr. Howe answer the part about infant feeding from the infant standpoint. But if a person is expressing milk as if they were exclusively breastfeeding, for example, pumping in between feeding sessions, then they may reduce this risk of subclinical or clinical mastitis. But there are still infant considerations. Both the sort of person feeding and the person receiving milk have considerations to biologically are relevant when considering the risks with mixed feeding.
Yeah, and that's great. So for the infant considerations, when you give formula feeding one feed and then you swap to human milk, the differences in the constituency of the milk can sometimes cause differences in gut permeability in the infant, right? And so that's the issue there. And if there were to be any, let's just say HIV in the gut flora, the translocation would be different. And what you don't want is a break in the gut permeability for the kid, which is also why we don't give cow's milk, right, before the age of 12 months.
Okay, there's a couple here that are addressing flash warming on formula. What is flash heat breast milk? How does one do that? And does it affect other properties of breast milk?
That's a great question, because I had the same one. What my friends have done in our studies in South Africa and such, there's two ways. You could flash heat in the microwave up to a boiling, and that's the fast way, but not everyone has a microwave in some low resource settings. Or you could boil up, just bring it quickly to a boil and then take it off the burner of the stove. Now, some people argue that doing that, then, do you denature any of the nutrients, blah, blah, blah. Then you have to wait a while to let it cool for the baby. So nonetheless, that is the method of flash heating if you want to, if you're worried because the mom has viremia on one of your viral load checks.
Here's another one from an anonymous attendee. We have a patient who is interested in breastfeeding, is committed to taking her own HIV meds, but does not want to give daily nevirapine to her infant for the duration of the breastfeeding. If this patient were in your practice, how would you counsel her?
Yeah, so I would probably have to look and see, has she been very adherent and had, a lifetime of undetectable viral load anyway. And then I would tell her the data on infant nevirapine is not such that we know for sure infant nevirapine added on when the mom's already taking 3 drugs is necessary. But we also don't know that it's not necessary. Mm-hmm. And so it's sort of like it's sort of like having an airbag 1 or having 3 airbags. And at some point, many people will go, you don't need 3 airbags, you just need the 1. But because we don't have data on it, that's why we choose to go ahead and give the infant nevirapine. Also, you just never know. When the mom is taking her HIV meds, we're checking the viral load monthly, but if you look at studies long-term and people with HIV in the early days, people would be on their HIV meds 100%. And then if you did a viral load every single day, there were still little blips here and there, not because of medication non-adherence, but simply because physiologically there may be small, tiny blips that you just don't even know about, right? And so does the extra infant nevirapine prophylaxis, which is a WHO recommended extended dose, help? We think so. Is it 100% obligatory? We don't know. What would I say to that woman? I would say exactly that. And I would say, how much risk do you feel comfortable with? And if she feels comfortable with absolutely, taking no infant nevirapine or giving no infant nevirapine, then I would make sure she understood, we're not going to give it, but this is the risk that you're taking. It may be small because I don't have the data, but it's not 0%. And go from there. But I would honestly try to understand why, like what is motivating her to not want to give the infant nevirapine prophylaxis, because that's actually that's the most benign thing I can think of to do. So
it almost seems like a disconnect.
Right.
I'm willing to take my medicine,
yeah,
but for whatever reason, I don't want to give it to protect the infant, which kind of doesn't make sense in a way, right. But I guess to that mother, we can't judge that it does. Excellent. To go along with that, there's another question that's asking about the duration of the prophylaxis. I thought you might have said that in your presentation, but maybe if you can address that again.
So again, no data on this, but we can borrow from our friends in Africa on what different countries do there. In the PROMISE study, which I gave you guys some data on, they continued the infant nevirapine through 42 days, I believe. No, sorry. Yes, let me rephrase that. Through 45 days after breastfeeding had ceased. And then that final NAT was done, I believe, after 28 days of no breast milk exposure. So what we typically do is I continue the nevirapine on the kid about 6 weeks after the last day of breastfeeding. And then we get a NAT test done then, and then we get another one at 12 weeks post the last breastfeed. Different countries do things different ways. Some people do a NAT test at 3 months after, and then they stop the infant nevirapine at 4 weeks after. So there's no right answer on this one. And so again, here's where got to ask your pediatric HIV specialist to weigh in, and it's very helpful. Yeah.
Here's another question and a statement. I've seen viremia occur when the patient gets sick, flu, etc. Are there any recommendations around what to do if the mother gets sick but hasn't yet had a viral load lab collected?
Yeah, that's a great question. And I will say one of the challenges this is a common challenge. Colds, COVID, all sorts of things can cause spikes in viral load that the person is not themselves aware of. And there really aren't any recommendations for what to do around this. The recommendations are situated around mastitis, which is a limited scenario. And we know there are other illnesses that can cause changes in the inflammatory state that can cause spikes in viremia. And as a clinician, I find this to be a worrisome aspect of the infant feeding discussion, in that people may have colds or other minor things that they don't need to seek medical care for, but that may trigger an increase in viremia that we just are unaware of. But thank you for asking that question, because we just don't have any guidance or any evidence.
Okay, here is another question. This question is around art as far as the safety. I am interested to hear on the safety of the HIV medications with human milk feeding.
Yes. So I could say that in the data that I presented, because it's all in sub-Saharan Africa, much of those were older regimens, and then some newer regimens out in Botswana in our Tilo de Kotla trial. In that one, the moms use tenofovir, FTC, and dolutegravir, or tenofovir, lamivudine, and dolutegravir. We don't really have breastfeeding safety on the very, very new antiretroviral regimens that we use in the US, because our guidelines have always said not to breastfeed. So hence no data. Yeah.
Okay. Here's one. It says, did the study explain what specifically causes higher mortality with mixed feedings?
No, but they controlled for several aspects, obviously, of, you know, socioeconomic status, income, birth weight, and et cetera. I think here's where it's not a mechanistic study, but it's more a population-based epidemiologic study, and the signal was there. We would probably need more mechanistic studies to tease out, you know, what's actually contributing most to that higher mortality. But the direct effect is still there.
Okay. All right, here's another question. Actually, this is about mental health. We have seen moms with untreated mental health conditions that took their medications while pregnant, but had a flare on worsening of their mental health after the baby was born and stopped their ART meds. When you are doing counseling with moms regarding breastfeeding, do you address, I don't know if the question was.
It's 2 comments down. Do you address mom's mental health history at all?
Okay.
Thanks for bringing it up, because it's really an important part of the holistic counseling about risks and benefits of breastfeeding. And I say specifically risks and benefits because there are risks associated with mental health disorder exacerbation, just like the person asked in the question. There are also benefits to breastfeeding with regard to mental health for some families. And so I think acknowledging a person's past mental health history, what they think, how they think they will do, what their social support is, and what they expect their mental health trajectory to be based on their lived experience is all a really important part of our counseling. And for families, individuals who have had a very hard time adhering to ART in the setting of mental health disorders, I would make a strong recommendation against breastfeeding or chest feeding if we think that's going to be a major challenge for them. On the other hand, pregnancy is a window of opportunity, and some individuals may see this as a motivating factor to maintain very engaged in mental health care. And as such, I think it's important to really individualize this counseling.
Okay. This next question, I think it's more of a concern about, okay, so I'll read it. I had a family where the mother wanted to breastfeed, but lived in a setting where transportation was difficult, unreliable. The mother was not reliable either. So I think what this person is asking is, how would you address this mom? Because the concern is that she's going to go ahead and breastfeed anyway without knowledge and without your knowledge.
Yeah, I mean, I think this is a tough one. And if this person lives very far away and is unwilling to see a pediatric HIV specialist, but is willing to see the primary care provider or the primary pediatrician, I would say to the primary provider, call us, and we will figure out an innovative way, right, to make sure that the baby is cared for and the mom is cared for.
Okay.
And actually, I would add to that, for those of you who are caring for patients where you think this might be occurring, where they're breastfeeding or chest feeding without their clinician knowing, and I think this is a good opportunity to ask them why. If you are in the community, in a patient's home, and you see this, ask them why they haven't shared with their clinician, and open up the opportunity to talk to the clinicians. And if you feel likewise that a clinician is uncomfortable with this and has a patient who's breastfeeding or chest feeding, encourage you as the nurse or home visitor or clinician yourself can call us. We're always happy to help from a hotline standpoint.
Okay. They want to know your suggestion. There's an individual who wants to know, what is your suggestion if the infant develops thrush while breastfeeding?
I mean, I probably not say anything different, but you'd have to take it in the totality of, is the mom viremic? Is she, for other reasons, would you want to stop? But just for the thrush alone is not a reason to
stop.
Change the infant feeding form.
Here's some research. Is there any interest in pooling data around breast chest feeding in Illinois so that we can try to prove what is working best? I know some other jurisdictions are attempting to collect observational data on implementation of these guidelines.
Yeah, there have been some discussions among obstetricians who care for patients living with HIV about potentially sharing data, not at the Illinois level, but really at the national level. So I think there is interest. I think any one state is going to have so few participants that we wouldn't be able to really scientifically assess anything with one state, but I hope that with coordinated efforts for national data that we might get there.
Okay. And then the last question is about mastitis, which I think already did get addressed earlier.
Mm-hmm.
Yep.
Those are all the questions that I see at this point in the Q&A. We've got a few more minutes. Actually, we're about 15 minutes away from being done with our program. If you have any other questions, please don't hesitate to put them in the Q&A.
I see somebody put another question in the chat. Is there a disruption needed if mom has open nipple discharge?
Oh, I see that
or
now.
Nipple damage. Sorry, nipple damage. I assume you mean like cracked or bleeding nipples from injury from breastfeeding or chest feeding. And yes, the answer is if there's cracking or bleeding, they need to pause until their breast is healed.
And I believe that would be the case for any woman that was breastfeeding. Is that correct? Any person that was breastfeeding?
Yes, for comfort, but a woman who had a sort of cracked but non-bleeding nipple without HIV could continue to breastfeed, but it would just be really uncomfortable. Yeah. I think one of the things we as obstetricians really need to do a lot of in the hospital for all patients, but especially patients living with HIV, is counseling about good breast care. And how to take care of your breasts and keep your nipples healthy in the setting of infant feeding. So that's an important part of caring for these patients. And I was really pleased to see that. I think there's some lactation counselors on our webinar today.
Mm-hmm. Okay, here's one. Can you discuss the process for obtaining donor pasteurized breast milk? That's an excellent question.
You know, I actually don't know the logistics of that. Do you, Lynn?
Yeah, so it varies based on locality. For example, I'll tell you where I used to practice in training in San Francisco, there was a citywide milk bank that could be donated to and received from. We don't have that in Chicago, and most places in the country don't. There are milk banks, though, that can be privately. Oh, and I will say for people living with HIV in San Francisco, when I was there was a way to get free access to that because of infant feeding concerns. That does not exist for us really in Illinois, but there are milk banks, and I can look up some and make sure to have those for our second presentation if that would be of interest. They're expensive. They rarely do free milk, but hospitals typically have information about this because many NICUs use donor milk. And so I would say to find out your particular locality's resources, ask the NICU or pediatricians in the hospital, and they'll provide whatever source they use for the hospital's donor milk.
Okay. Is it ever recommended for persons with HIV to provide colostrum only, just for health benefits and to prevent mortality?
I think
Go ahead.
It would not differ from breastfeeding recommendations in general. Like I would say if somebody desired to do that, that would be okay under all the other circumstances we've discussed. But I think the benefit of colostrum only is relatively small.
Okay. And there's another one here. Is there any information available on the use of nipple shield to prevent the cracking of nipples? I had a patient ask this, and we thought that it would be different than the use in non-HIV positive women.
I see that it says that we think it'd be no different, and I agree. I use nipple shields, or I would feel comfortable using a nipple shield in a person living with HIV, but we don't have any evidence to guide that.
Okay. Laurie just posted in the chat the phone number to the perinatal hotline if you have any other questions. Thank you for that, Laurie. Is there any other questions? Anything else you ladies would like to add, Dr. Yee or Dr. Howe?
No, I just want to say thank you. It was a fun discussion, and we're here to help you guys and support you through the hotline. So give us a buzz 24/7 if this topic comes up or anything else in perinatal HIV.
Okay, thank you so much. What an informative. I'm glad I have a voice now. What an informative presentation. You know, when if you live around HIV community for any time, you know, the pendulum keeps swinging, and now we've got another different swing in a different direction. This was great information, and for anybody, those guidelines are out. I believe they were published in January, February.
Mm-hmm.
Yep.
So please take a look at them. They've even got some that are condensed, so you don't have to read through all the technical things that these researchers had to read through, but they're pretty concise and very informative. Estella, anything else? I need to interrupt you. There's a question here, ladies. Wants to know if the American Academy of Pediatrics have gotten involved with these updates yet.
I just put in the chat to Jill, but COPA is working on it. I'm on COPA, so.
Oh, okay.
We were waiting for the federal guidelines to come out.
Excellent.
Yeah.
We are so very, like Estella said, we are so very fortunate to have these two researchers, these two cutting edge professors and physicians here with us to be able to tell us this information firsthand. So grateful, so thankful.
We really hope you'll come out for our second one, where I'm going to interview some of our frontline case managers, perinatal enhanced case managers, about their experience caring for patients living with HIV who desire or perhaps don't desire to breastfeed and chest feed. So I'm excited to have them share their stories with you all.
Yes. And with that, I think we can end.
Great. Okay. It was a real pleasure. Thank you, everyone.
Thank you so much.
Thanks,
Bye-bye.
everybody.